Good afternoon, I'm Katie. Thank you guys for taking the time to listen to this. I am a speech-language pathologist. For the speech-language pathologist listening, some of this might be old information, or if there's something specific that you had questions on I didn't address, please feel free to email me and I'm happy to do that. I wanted to leave it a little bit broad since there are so many different disciplines. And my main objective was to provide some information that of hands-on things that could be provided to patients and caregivers in the moment. That was one thing that was really requested. The other thing people had asked about was different assessments that are being used that are standardized. So I tried to not get too far into detail with that, but to provide resources, and I'm happy to further discuss that if anyone has questions about that. So I tried to cram a ton of information in a little bit of time. I won't be reading everything off the slides. That's why some of them have extra information. And again, this is just a very, very broad brush overview of things we can offer patients with communication, cognitive, linguistic, and/or swallowing disorders. So one thing I really spend a lot of time with my teams talking about is to first and foremost make sure the patient has adequate language function prior to doing the cognitive linguistic function. And in the speech world, we do separate the two, dealing with language skills first, and then later addressing cognitive linguistic functions as the patient is able. There is this website that addresses a pretty exhaustive list of standardized language assessments. It also has cognitive linguistic assessments, which I should have updated this slide after I finally read through all of them. And it gives the purpose of the test, if it's recommended by the publisher or speech language pathologist, and it also provides the standardization sample and a brief little blurb, if you will, to just talk about how it was tested so you can decide if that's a test you want to use. There's also a recent published article that talks about the diagnosis of aphasia and stroke populations, and it's another pretty exhaustive systemic review of language tests. So these are two really good references, particularly for speech pathologists if they're looking at standardized assessments that can lead you in the right direction. So in general, which I'm sure everybody's aware, but I always like to review this at presentations, when we talk about language, we're dividing it to receptive and expressive language, and it's not as common for our patients to have deficits in just one area, but typically both, although obviously it's possible depending on where the brain injury is. So we're thinking of receptive language, we're thinking of how is their auditory comprehension and how are they comprehending what they hear, knowing that most of our patients' primary receptive language is going to be their auditory comprehension. Most of us communicate by listening. And then our expressive language with their verbal output or their word finding and written expression. And again, knowing that most of our patients primarily communicate verbally. So these functions need to at least be adequate, not necessarily normal or baseline, before even thinking about proceeding to cognitive linguistic tasks. If our patients don't have the foundation and they're not understanding basic information following commands, or don't have the foundation to retrieve the words they want to say, then testing memory, problem solving, attention is really not fair or appropriate with these patients if they are not able to state basic words and tell you basic wants and needs. When you're doing your orientation assessment, they're having to process what you're even asking them, then retrieve. So if you ask them what month is it, they have to even understand what does that mean prior to thinking of the 12 different choices it could be. So it's really important that we assess that they have a foundation in language before we assess their cognitive linguistic function, giving them the best opportunity. So in general, as I'm sure most of you know, aphasia is just the medical term for language deficit, whether it's reading, writing, verbal expression, or auditory comprehension, typically from left hemisphere, but as we know, everybody's wired differently, and it certainly can happen from insults in the right hemisphere, but most often in the left. There's a bunch of different subtypes depending on the severity and what type and comorbidities. The impact of this aphasia could be minimal to quite significant, and therefore we need to remember that there isn't a golden standard. Not one size is going to fit all. that we need to take each patient by patient. And we know general strategies and general activities that will help them, but keeping in mind that one thing is not going to work for every patient and can actually be frustrating, and the patient can actually decompensate and do worse and withdraw. So this is just a nice little model I found. It's just a little flow sheet. It's not so important to everybody, but it just demonstrates the different subtypes. And as speech pathologists, it's very important to us which type of subtype, because that's going to drive our care plan. So it goes through, are they fluent or non-fluent? Do they have a lot of output, or are they not having a lot of output and a lot of hesitation? Are they comprehending well or not so much? Are they able to repeat? It doesn't address word retrieval on this, which I probably would do, but it's just, it's a nice illustration to show the multiple different types of aphasia, so everybody can appreciate that one type of aphasia isn't equal to another. I really liked this group of researchers that spent a lot of time in telling us what is the recovery, what is the prognosis. And one of our main points in Compass is recovery does happen over a lifetime, and just because that patient's out of the acute phase or been in therapy for quite some time does not mean that they will not benefit. And we know that severity, lesion site and size are good predictors, as well as all the other things listed. But really the take home is we don't want to just stop trying. We want to give the patient every opportunity to continue recovery throughout their lifetime. And we know that beyond communication and the loss of being able to make choices and tell people what they want and need and understand basic information, social isolation and depression are also results of having these communication impairments, which makes sense if you think about everything we do revolves around communication, whether it's events and you're chatting with your friends and your family, or celebrations, or just being able to make very, very simple choices as to what you want and need from a day-to-day basis. So it's very important that we do continue to work with these patients so long as we can do anything to help them. So when you have your patient, when you have a patient that has difficulty with communication and you suspect for aphasia, the things we think about is these are things the patients say. I know what I want to say and I can't say it, or it's stuck on the tip of my tongue, or perhaps they're using the wrong word, which is an accurate word, but just not the appropriate word within the context of what they're saying, or they may even use made-up words. Sometimes they'll say a word that sounds like another word, and they have trouble formulating sentences as agrammatic. Or they could be saying a whole lot, and it's just not really making sense to us. So anytime these situations come up, we want to really think about getting speech therapy intervention to address. So the kind of a review earlier, but a little bit leading into our next slide, is we really do want to take into account severity and knowing that not all patients with aphasia are the same. And we need to think about how frustrated are they, how aware are they, is there anything we can do to help them, and what is our support system. Every patient deserves speech therapy intervention and every resource we have to offer them, but it's going to vary as to what that person might need. So this is just literature that is in support of speech and language pathology intervention, just an article for reference. It covers 57 different studies, and it reviews what is the effect of speech and language therapy in adults post-acute that have aphasia. And so these were the specific questions and the aims that were addressed. I'm not going to read them all to you. The gist is, does speech and language therapy from a speech and language pathologist result in a better outcome as compared to not receiving it? As well as they looked at other factors such as time, duration, frequency, intensity. So what they found was that functional communication is significantly better. And then, of course, just like PT, OT, and all our therapies, we want high intensity, high dose. But the important thing is this article really demonstrates from a review of 57 different literature articles that the intervention from a speech and language pathologist is definitely significantly better. So some basic tips and tricks of things you can provide to the families or the patients, the caregivers in the moment are some things we think is common sense, but are so common we often forget about it. But I always tell people to keep the information simple and basic. We want to give the patient as much time as they need within reason to respond, noting that if they're getting frustrated as you're sitting there just staring at them waiting to respond, that it's okay to jump in a little bit. But the one thing I think that patients and families and caregivers do well-intended that is destructive is, what's my name? Tell me my name. You know my name. You said my name earlier. And it's just this auditory bombardment. So we're setting the patient up for failure. So really giving that patient additional time to respond, knowing that it's going to take additional processing time. Eliminating distractions within the room, whether it's the television or children or chatting family members and visitors, or their cell phone or whatever else is going on in the environment. And making sure we're in the patient's optimal visual field and speaking directly to them, giving them the eye contact they deserve. Simplifying your information to basic yes and no, one or two choices, and asking them only to do one thing at a time, not two. So just, again, more common sense things that often get forgotten. Anticipate what your patient might be asking for, because oftentimes these patients can't initiate on top of not being able to actually say or tell you what they want or need. Supporting the auditory message to the patients, whether it's gesturing or providing pictures or providing written word with the pictures. The more information you give them, the more successful they're going to be. Remembering not to speak for them, but assisting them in minimal ways to give them the best opportunity to be successful for what it is they're trying to communicate. Letting the patient attempt to respond, and then maybe giving them the first sound of the word to help them get it out, but not speaking for them. And patients will surprise you. They often can write more than we give them credit for, and although they can't verbally tell us what it is they want or need or they're trying to communicate, they can write a message. And it may not be super clear, but it may get you to the next step to getting what it is they want or need. So one thing a lot of my family members ask me about is when the patient is so low level, there's really just like, what in the world can we do? It seems like the patient's not talking. They're attempting to talk, but it just sounds, it's not intelligible. So these are some really basic things that caregivers and families can do with their task, cautioning them that if the patient is frustrated, to take rest breaks. We don't want to stress the patient, we want to help them. And families and caregivers working with the patient is much different than a therapist, and we want to keep that family-caregiver relationship and not a therapist relationship when the families and caregivers are working with them. But these are tasks because most families and caregivers do want to work with them to facilitate optimal verbal output, and they get excited and they're enthusiastic. So I still like to provide tasks with that word of caution. So music is wonderful. As we know, it incorporates different parts of the brain, motor parts of the brain. So patients who are having trouble talking conversationally will start to verbalize in unison with music. So there's a lot of literature about music therapy, about melodic intonation, but then also rote speech, singing things that are familiar. So we then can take two things to tap into the different areas of the brain to get verbal output, and hopefully using that to functional verbal output so they can tell us what they want and need. So if the patient has preferences of music they like, if they're churchgoers and there's religious music or whatever their preference is, I always encourage family members to use that. Rote speech tasks are things we do on a regular basis. We don't even know we do anymore. But it's something that's ingrained in us from a very little, as we're small and young, and it's very familiar, and most everybody can count or know the days of the week or maybe the months of the year. So practicing those, because those are more automatic tasks. So these rote tasks are anything that might be automatic. And also, when families are working with their patient or the caregiver, they often want to get a deck of picture cards or word cards. And I really ask them to choose the age-appropriate ones. We don't necessarily want these cartoonistic ones. We want something more reliable. And we also want something that's relevant. So I often even encourage families to take pictures of things around the house or take pictures of things that are important to their loved one and use those rather than having these cartoonesque picture cards, and just providing the first sound of the word to help them get the whole word out. Another thing is the patient isn't talking at all, so obviously they can't do anything, which is very far from the truth. So we always look to see, is there a physiological reason that the patient is not talking? Do they have a vocal dysfunction? Perhaps there's an apraxia present. So ways we can assess just to know really quick, are they even capable of getting a voice? There are vegetative functions such as sighing, coughing, yawning, those types of things. Humming in unison. That's another way just to see if we can at least achieve voicing to get it to a functional verbalization. For patients who just absolutely aren't yet demonstrating mouth movement or talking, we try a lot of things with eye gaze. Maybe holding two items up and seeing if the patient can shift their eyes to the targeted item. And this is really great because, again, sometimes patients really surprise you, and these patients in particular have lost the opportunity to make even the most basic of basic choices. So just showing them if they're able to eat and drink, and you're showing them an apple juice and an orange juice, if they're able to consistently look at one or the other, we've given them that opportunity to at least make some sort of choice. I do caution people with the communication board to start with maybe two icons to make sure they can eye gaze at two options, or make sure they can eye gaze from yes to no, before we give them these pre-made picture boards that have 15 plus icons on them, because those can often just bombard them. And again, rather than optimizing them, we're being destructive. So we want to ensure success before we make these large boards. And then there are a tremendous amount of resources for alternative and augmentative communication. And I did list the website here. The website is super user-friendly. There's even a tab on there like how to make a referral. The North Carolina Assistive Technology program here, it just talks about it's federally funded and what they do. I've had very good success getting loaner devices free of charge for my patients. There is a huge array of what they have, from the lowest to low tech, which is switches and eye gaze devices that speak for the patient, on to higher tech things. They offer devices outside of what I do with adaptive equipment, rather with other OT and PT activities. But it's just a great program that offers so much to our patients, and they really work with you on getting funding. So here in North Carolina, there are centers all over the place, and if there's not one near you, you can always go on that website and they can hook you up with the closest one. But there are quite a few across the state that offer devices not only for communication, but other adaptive equipment that I was talking about. I'm not going to read this long slide to you, but I do have handouts that are much more visually friendly that say just about the same thing. But one thing people had requested for me is something concrete that they could provide to patients, caregivers, or families about what can they do. Everybody wants to help. So I've divided it up into activities versus strategies. So this is just a list of pretty basic things that people can do within their home that's a regular daily task, less therapy drill-like, to incorporate doing therapy, communications in everything we do. So these are things that aren't so much like just going back and forth doing therapy tasks, but rather doing functional tasks or ADL tasks, or looking through photos and magazines that's relative to the patient, but really stimulating that language. So these are things that are meant to be enjoyable while helping the patient. And again, when the patient's frustrated, or if it's something not of interest to them, we don't encourage it. But it's just a quick and easy reference of things you can do to facilitate language. So these are just ongoing activities for, this is for auditory comprehension. The first one was for word retrieval. So these are different ways to to work on how well is the patient understanding what they're hearing. Again, working in daily tasks or ADLs, engaging in conversation that's of interest to the patient, or playing games that's of interest to the patient. So dealing with shifting to cognitive linguistic, once we've established the patient's language, is good enough to proceed with cognitive linguistic intervention. Shifting to typically the right side of the brain, but again, we're all wired differently. We want to think about these patients typically have a high risk for dependence. Their impact is variable on their day-to-day life, just like it is across all of our disciplines. And we need to really keep things individualized, just like we do with everything. So when we think about right hemisphere damage, again, I'm not going to read all of this. I just like to include all the information. I'm a very visual person. You can go back and reference it if that's what's best for what you do on the day-to-day. These are all the things that come to mind that impact our safety and our ability to be independent again, to assess how well we need things, what support level we might need in place, thinking about financial medication. Whoops, speaking of speech errors, financial management, medication management, being able to manage their calendar for their doctor's appointments and therapies appointments. And again, this all comes from ASHA, American Speech Hearing Association is our national board, and this is directly from their site. And I just wanted to reference that. But this is just an easier on the eye visual chart of the things we're thinking about when we're talking about cognitive linguistic functions. So it makes pretty good sense why our physicians often want the MOCA right away in a stroke patient, but this is why we argue not all patients can do the MOCA. If you're thinking that they can't retrieve words, we can't be asking them to do these higher level skills that require at least a strong language foundation or good enough language foundation to do that. So these are some tips and tricks of things you may want to do to address specific dysfunctions. Again, a lot of people want things they can give immediately to their caregivers, the families of these patients. Some very basic in the home things they can do. We try to keep everything functional and close to like real life activities rather than keeping them therapy focused. Keeping a calendar for their medical appointments, for their therapy appointments, birthdays, anniversaries, or even maybe when they need their medication refilled. Being able to complete a pill minder task with your patient, seeing how they're doing, setting it up, and then their family can talk about how they're doing actually managing their medications with some supervision. A lot of these patients will have poor insight, so we do want to try to make them aware of their deficits, because we know from the literature patients who are aware of their deficits do better in therapy, but trying to balance that frustration level. Checking in with the patients and saying, how do you do with that if they're aware that they're making errors. Another question people had asked me about is what cognitive linguistic assessments do you do? Again, the reference in the beginning has an exhaustive list, which also includes additional cognitive linguistic assessments. These are the ones that are most often used around here. Obviously, the mini-mental and the MOCA are more of a screener type, and the other ones offer more detailed information. So just going into the right hemisphere dysfunctions and real-life strategies we can provide to patients and caregivers in the moment. These are things they can use in their everyday, on an everyday basis that will be helpful. And these are also included in handouts, so I don't want to read off the whole list. And again, some of them seem so basic, but we often forget in the moment. Things I highlight to patients, of course, I've already talked about a calendar and a pill minder, but also setting timers when they're doing tasks, particularly for severe memory impairment that might impact cooking, or maybe forgetting to even get their laundry out of the laundry machine, and these types of things. Eliminating distractions is the biggest one I emphasize, because if we can't pay attention, then we really set ourselves up for failure across all activities. And then these opposed strategies are the actual activities. These are things they can do from the at home or wherever that are going to help them with those specific deficits. Again, these are just not an exhaustive list, but a pretty good list of strategies to maximize attention, minimizing distractions, and things that the caregiver, family member, whomever can do to communicate to get the patient's best attention, emphasizing that the patient's going to need you in their best visual field, looking at them, that we need to be clear and concise, also allowing breaks. When a patient has trouble with attention, they're not going to pay attention to a full conversation if you give them multiple steps to do. Even if they have the comprehension to follow a couple of steps in a row, they're not going to have the attention to do all that, particularly when there's a motor task involved. So these are just strategies to make sure they're doing the best with their attention they can for the patient's success. And again, just some activities that the patient and caregiver and family members can work on that's actually very therapeutic, but more functional and related to ADL type things. These activities are things that should be relative to the patient, but also things the patient enjoys. Again, if it's something they don't like or they're getting frustrated, it's not going to be very constructive. Although we know we're going to push them to limits and frustrate them, and that's a good thing, we don't want someone to be working on board games if they've always hated board games. So when we think about thought organization or sequencing, of course, attention and memory play into all of these things. So some of the strategies overlap. And then these are just some activities that the patients and caregivers and families can work on outside on their own that are quite therapeutic. Again, very functional in their day-to-day activities, things that they're going to be doing anyways, but they're going to need support to be doing while they have brain injury and they're recovering. So these are things within their household that they can do to maybe feel like they're actually contributing. A lot of our patients feel like they don't have a purpose, or that they're not doing anything purposeful, or that they're a burden, or that they just don't really have any worth. So something as simple as being able to sort the laundry or the mail is a helpful household task that's going to include them and give them a sense of purpose, and probably even some pride and satisfaction that they're able to contribute to their family's day-to-day and have a place in the home, that they're functioning as a family member. If they're packing for a trip, that's another one that takes several steps and taps into multiple of the executive functions we've been talking about. So these are pretty basic things that most people do on a regular basis and can very easily be therapeutic. These are some support groups, probably more biased towards the area that I'm in. That's why I'm more familiar with them. But the brain injury support group, we do have one that meets here at our inpatient rehabilitation. But even if you're familiar with the Brain Injury Association of North Carolina, they have meetings across the state, and you could go to their website, which I should have posted, and I apologize, but it's BIANC, Brain Injury Association of North Carolina. If you go to their website, I would pretty sure they're across the state. We have an aphasia conversation group here. Locally, there's a Carolina Center for Cognitive Rehab that has a stroke support group here. They have multiple support groups there. I spoke more to stroke for the purposes of this talk. And then there's the Triangle Aphasia Project, which is speech therapists out there. I can't remember if it's Raleigh or Durham specific, that has satellites out.
They actually are in Raleigh, but they've branched out to the whole Triangle area, and in some cases beyond. I've heard the director there speak at a stroke advisory council meeting, and they're trying to branch out even farther.
Yeah, and yes, and so we do have one here, but that's exactly right. They are branching across the state, so I've included that reference. And then the aphasia support group we have, there's multiple across the country, and so I just listed the site for that. And then the American Speech and Language Hearing Association, our national board, does have something called Let's Talk, and these are 19 different patient education handouts for adults in very simple language. They do have DVDs. You do have to purchase them, and they are very, very simple. Most of my families very much appreciate them. It's just a very quick and dirty, this is what the deficit is, this is what can be done, and here are some suggestions. And just before we're all done, we're going to shift topics very, very briefly to dysphagia. Several of our patients obviously have dysphagia, which is just difficulty swallowing. And this increases the risk of aspiration or aspiration pneumonia or inadequate nutrition and hydration. So if there's any concern, then I would strongly recommend speech language pathology to do the evaluation if it wasn't already done. Speech pathologists will always start with a clinical swallowing evaluation, which is oromotor assessment to assess cranial nerve and muscle function, giving some PO trials to see how the patient's tolerating it, and determining if the patient needs further testing that's objective. Depending on the literature, we know that 40% of the most experienced speech therapists can miss aspiration on a bedside, which is kind of scary. I'm sure none of the speech therapists here have done that. We also know there's a certain patient population which has a higher risk of silent aspiration, which obviously they're going to aspirate, not show us any signs, we wouldn't know they're aspirating. This is particularly relative to our brainstem strokes, subcortical strokes, prolonged intubation. So these are the patients that often in the acute setting we do proceed to instrumental assessment, although the clinical swallow wasn't overly concerning. If we decide to go on to instrumental assessments, the two ways to do that is a modified barium swallow study, or you might hear video fluoroscopy or pharyngeal function study, but basically it's a video x-ray, which is what the first picture is. All consistencies are mixed with a barium powder so we can see it under fluoro. Or the speech pathologist may perform endoscopy, or this is a typo, it's supposed to be flexible endoscopic evaluation of swallowing. Sorry about that. But the picture on the bottom right shows that. So it's direct visualization. You can see the anatomy. We're looking how the vocal cords are moving and secretion management, but then also the swallowing function. One test isn't better than the other. They both are different ways to look at the swallow. There's different reasons a speech pathologist may choose one evaluation of the other. In the acute setting, we tend to defer to the fees, because we can bring everything to the patient, which is a big deal, not having them travel. A lot of times we do want to see what their secretion management and vocal cord function is like. You also aren't giving the patient any radiation exposure, so you can do the study a little bit longer if need be. There's no time constraint. However, there are patients that have facial fractures or other surgeries where we can't go through their nose or it's contraindicated. Patients may be too agitated. It is a little bit more uncomfortable to have a scope through your nose than not. If patients are severely confused and don't understand the procedure once you start it, sometimes they will fight you on the fees. If we have trouble, if we do our fees and don't feel like we can see everything, we'll go on to the modified barium swallow. The modified will give us better visualization of the oral phase. As you can tell, when you do a fees, I'm just looking at the pharynx, and you only see the esophagus when you belch or swallow, and the epiglottis there on the top will fold and cover that, so you don't get to see how the how the esophagus is opening and relaxing, and you don't get to see as much as the oral phase on the fees, which you can on the modified. But for different reasons, one may be better for certain patients, but in general, there's not a gold standard, which is controversial. Once we do our swallowing evaluation, there may be compensatory management or diet restrictions that we suggest. Most often, people are familiar with thickening liquids. Thickener can be purchased at any pharmacy over the counter. I find that most pharmacies carry a powder-based thickener. There's a gel-based thickener available through certain companies that mostly is ordering here locally in Winston-Salem. We do have pharmacies that carry it. We may modify their solid textures or how they take their medications. or we may recommend postural techniques or strategies. Something I caution is people in good faith will say, oh, just tuck your chin and that fixes everything. And I really wished it were that easy. It would make my life a lot easier, but that's not true at all. And it actually can increase aspiration or increase pharyngeal residue and difficulty. So it's really not appropriate to be giving postural techniques unless the patient's had instrumental assessment, and that was a recommendation from the speech and language pathologist. I do try to provide thickener kits and thickener education prior to my patients leaving the acute care setting. That doesn't always happen, but most companies will give you free sample kits. You can go online and check the different companies to provide to the families if they need that. So some of the risks associated with dysphagia, other than the obvious of the patient getting aspiration or aspiration pneumonia, is noncompliance, and it may not even be because they just don't like it, which is often the case. They don't like it and no one's there, and they, particularly if it's silent aspiration, they don't really believe in it anyway. But patients may not have access to thickener, they may not have been properly educated how to thicken accurately, or maybe they received the education and just couldn't retain that. There's so many other things going on at that time. Patients can get dehydrated. We know that as things get thicker, they may have to up their consumption to maintain the same hydration. Or again, if they don't like it, they're just not going to drink it at all. They may not eat as much because they don't like the texture we've put them on. And often patients who aren't followed by speech and language pathology are on a restricted diet unnecessarily because they haven't been reevaluated. So our objective as speech language pathologists is to put the patient on the least restrictive diet while keeping them safe. So we're doing ongoing monitoring. Something to consider is the Fraser Free Water Protocol, which is a study that was done out of the Fraser Rehab Institute, and it found that known aspirators could have water, even though we know they're going to aspirate, under specific guidelines, and they were safe. And without giving too much nitty-gritty that maybe not everybody needs to know, the gist of it is oral care is the most important thing. In general, our patients should be receiving good oral care because they perhaps are aspirating their own secretions anyways. However, if we're going to allow our patients to have sips and chips, they absolutely must have oral care. There is an exclusionary criteria of which patients might not best be fitted by this, such as pulmonary diseases, etc. But most patients can tolerate at least ice chips after oral care, particularly if you're in an outpatient or home health setting. I do this very often even with my ICU patients. I'm obviously very careful when I'm choosing them, and I know that I can monitor them. But most of the outpatient home health patients can do this under the right guidelines. So providing oral care, then allowing them to have sips or chips, whatever is at the speech pathologist's discretion. And this not only is good for patient comfort, but the best thing to rehabilitate a swallow is to swallow, to use the musculature for what it was designed for. So patients who are strictly MPO are further behind because we're taking away food and drink. They're going to have more dry mouth and less saliva, so they're swallowing less because they're not taking in anything, as well as they have less saliva to swallow. So giving them sips and chips at the discretion of the speech pathologist after good oral care gives them back not only some comfort, but also is giving them therapy to continue using the musculature. We found that patients that are allowed to clean cheat, so to speak, having sips and chips in between meals, if they are on an oral diet, are more compliant. So we do use a modified Fraser Free Water Protocol in our ICU and acute care floors here at Wake under really individualized basis from the speech and language pathologist. This is just a list of all the references